lot of the areas we've been talking about today that are changing in psychotherapy. So officially, folks, psychotherapy changes the brain. When I show my depressed people an emotional word, their amygdala is active. If I bring them back 8 months after psychotherapy, not so much. Just like controls my post-therapy depressed people. Same here with putting numbers in order. Pre-therapy controls, post-therapy depressed. It increases. So amygdala activity decreases, prefrontal activity increases. So maybe we're affecting the right mechanisms. So depression involves this increased amygdala reactivity and decreased control. Let's see if we can use it clinically. Who would it work for? In general, other medical diseases, you come into the doctor and say, "Doc, I feel like I'm going to die." They do a test, and based on the test, they give you a prescription, or they give you a treatment. Depression, "Doc, I feel like I want to die." Oh, and I'll give you whatever it is I'm trained to give you, a pill, a therapy. Where was the test? We still don't do a test. Why in these other medical specialties? We knew the mechanism. Depression, we're starting to know the mechanism, so we should be able to say who it would work for. Who would psychotherapy, at least cognitive behavior therapy, work for? If it's helping people to interrupt negative thinking, it should be the people who have that negative thinking, the people who have that sustained amygdala activity. If we look at what Dr. Greenfield might say, recent developments in the biology of mental disorder have made the old organic and old psychogenic positions equally obsolete. We should start to integrate them. The people with the sustained amygdala activity, turns out, are the ones who get better. This is how much residual symptoms you have after treatment, or how much you changed controlling for initial severity. The people who have lots of sustained amygdala activity get better in treatment. The people who don't, they didn't need what cognitive therapy had to offer. Turns out that's a lot like a study published by Turan Canley a couple of years ago that also said the same thing. He measured people 8 months later when they got therapy or SSRIs. Turns out if you give somebody a medication like an SSRI, you put the amygdala in a dish of serotonin, it shuts off. People who had more amygdala activity got better. It's been replicated in anxious adolescents who often turn into depressed adults. We've replicated it in depressed kids. More amygdala activity, more better in either drug treatment or psychotherapy. Let's look at what's specific. Where in the brain changed most in response to psychotherapy, or best predicted response to psychotherapy? Turns out it's one of those ventromedial regions, the sort of proximal regulator of the amygdala, the thing that would shut it off, the subgenual cingulate. Less activity means more change. If you're somebody who can't regulate your emotions or can't bring on these regulatory structures, maybe you need what psychotherapy has to offer compared to the people who have lots of activity there. I'm saying it as if it's causal. I don't know. What I can tell you, people who have less activity respond better. Cynthia Fu in England showed the exact same thing. She plots things going the other way on her axes, but it's more decreases in symptoms go with more amygdala activity, or go with less activity in that subgenual cingulate area. We've now replicated that in both of our other samples. If you look at what the area that best predicts responses in the whole brain, 2 other samples, you get the exact same region as our first study. Less activity means better response. Given that I've got this now in 3 samples, I'm going to suggest we have something that's kind of prognostic for response that maybe we could start using clinically once I do a big enough study. And we're in this new study where we're going to recruit 70 patients. I've been talking a lot to insurance agencies lately and saying, so what would it take for you to use this in evaluating somebody's candidacy for psychotherapy? They say, I need 100 patients and I need a huge effect. So we've got our work cut out for us. I told NIH, they gave me a grant to go look. Go figure. Let's think about medications. The interesting thing about medications is it goes in exactly the opposite way. Helen Mayberg kicked us off in 1997 where she showed us the responders to an SSRI have more activity in those ventromedial areas. A little higher area than I was talking about, but a lot the same function potentially compared to non-responders. Diego Pizzagalli showed it with EEG. Richie Davidson showed it with fMRI in response to venlafaxine here, which is an SNRI, but it has the same properties. Here, more activity in this area is better response to therapy. And then Jack Nitschke showed it with Ned Kalin, showed it in GAD adults too. Same region, more activity, better response. This is getting really interesting, folks, because potentially, if we're right, there's an algorithm here. You come into the clinic and you get your brain measured. If you have that high level of reactivity, if you're somebody who cannot regulate, you can't use those ventromedial areas, maybe you need cognitive therapy. On the other hand, if your regulatory mechanisms turn on just fine, maybe you just need a little pharmacological help to damp down all your reactivity, your amygdala reactivity. SSRIs maybe help those who regulate best. Can you imagine a couple of years hence coming into a clinic and saying, "Doc, I feel like I want to die. Okay, let's scan your brain. Now I'll give you psychotherapy or a medication." There's a group I'm leaving out here, and it's a huge group to leave out. What about the people who don't have that high amygdala activity? What do we do for them? We actually don't know, and very little is written about these people. Maybe they just need more of the same. You know, we didn't measure them for long enough. I was talking to Aaron Heller today, who says that that maybe you just need to wait longer, and at 24 months or something, you'll find other areas. Potentially, they need other treatments. In Canada, we used to take people who came in for whom the world wasn't negative. They weren't ruminating. It was just blah. They couldn't get out of bed, and we would give them amphetamines. And they got out of bed, and they got better. Maybe behavioral activation, other kinds of treatments. We'll see. Studies in progress. Oh, and for Dr. Greenfield, psychophys works too. I can measure your pupil. The pupil's really cool. It's innervated by just about every interesting brain area, more amygdala activity, more prefrontal activity, all more pupil dilation. Depressed people have more sustained pupil than healthy people. And if you look over in this area here, this very sustained dilation long after they see an emotional word, here are my responders to therapy in pink below the line. Here are all my non-responders above. The people who have more sustained pupil don't respond to psychotherapy. So I image their brains, and I see in these people, the correlation is with prefrontal activity. The more prefrontal activity, the more pupil you have, the less amygdala activity, the more pupil you have. The people with prefrontal activity are not my responders, low prefrontal, my responders. It's the same story, and we can do pretty well in prediction. I think this was all but 3 of our people were predicted correctly just from pupil dilation. So you come into the doctor, put a video camera up to your eye, measure your reactions to some negative words, and tell you what you get. Hopefully in a few years,